This our opening panel is our last final panel. It's our CIO panel. And this is going to be hosted by one of our board chairs. This is Dwayne. Many of you have met Dwayne. Dwayne's been pivotal in putting this together, this event today. And again, we appreciate welcome and out. So, Dwayne, I'll hand over the mic. If you want to introduce the panel, it'd be great.
Thanks, Dylan. Like I said earlier, one of the funnest things I do is facilitate the advisory group of CIOs. It's been an interesting journey. As one CIO said, it's a therapy session for some of them. It's a chance to get away with people that are of the same mind, do the same job, and just really talk behind the curtain of what happens. So we've got an opportunity to talk about innovation. I thought it'd be really interesting to finish this up, talking about innovation behind the curtain. What these folks here, disparate different organizations, what they actually feel, what they actually come across and things. So to start off, if you just introduce yourself, the organization you work for, and then we'll kind of get into some of the questions we talked about earlier.
That's good. My name is C.K. Venkatraman, Chief Product Officer for Veraho Health. I run a product, business operations, and digital side of Veraho Health. Veraho Health is advanced primary care organization providing on-site or near-site care centers. We are primarily in the past focused on direct-to-employer contracts, and a year ago we pivoted to support payers, and now we have 3 payers that we're supporting as the payers go to the pay-rider model of creating care centers for their employees or their members to drive access or reduce access issues. So we have, I think Drew talked about Blue KC. Blue KC is one of our partners in Kansas City, and we provide advanced primary care for them. Locally, we're going to start partnering with Ravenna, and we also have a partnership with Providence in Nevada, where we take care of commercial and MA population.
Good afternoon. Scott Walters, I'm the Chief Information Officer for Overlake Medical Center. We're a 350-bed not-for-profit hospital across the lake there, serving the east side with a fairly large clinic network as well.
Good afternoon, Zafar Chowdhury, SVP CIO, Seattle Children's. We're a pediatric health system here in Seattle.
Hello, Ellen Wiegand, CIO at Virginia Mason Medical Center. We have a hospital here in Seattle as well as a multi-specialty clinic and a hospital in Yakima, along with a large ambulatory practice in the Central Washington area.
So maybe I'll start off. For you, Virginia Mason, what does innovation success look like? How do you judge that?
Sure. So at Virginia Mason, we define innovation as directed creativity implemented. So for us, success means addressing a really high-value issue, aligned with our organizational goals, and implementing something that really sticks and resonates with our providers and our patients. So I'd like to think about it as kind of a 3-pronged approach as we're implementing new technologies. We have to find something that is really functional, so it meets the functional need. It has to be usable. We have to really like to use it. We want the providers and the patients to want to use our new tools, and we have to do it in a way that we can sustainably support and provide reliability. So if we hit that sweet spot, that to me is success. And I will say we have not always done that. So I would also say success is in recognizing when we're trying something really good, but we haven't quite hit the mark and we can shift direction and make a change to improve our current technologies.
Sounds good. Do you want to?
For me, innovation is about technology supporting clinical benefit, clinical value, or patient safety. My experience, though, is we just keep spending lots and lots of money on technology, and it has no real benefit. So I challenge anybody to show me an innovation model that has a return on investment, and that's what I struggle with.
That's hard to follow. I look at innovation specifically within healthcare. It doesn't have to be implementing something new and novel. It could be borrowing from other industries and just doing it well. For for myself and my team, doing that well is addressing the problem statement back to, I think Dr. Clark mentioned, what's the problem we're trying to solve. So let's work backward from there rather than chasing the shiny object, a new solution that someone went off to a conference and found out it was the greatest thing. But doing it well and addressing the people side, which is the change management side. Being deliberate about that, building that into the project plan in a deliberate way.
So for us, it's the continuous improvement. Our culture is a continuous improvement culture. So we always look at what is this innovation drive? Is it driving patient member experience? Is it driving health outcomes? Or is it driving some levels of efficiencies within the organizations or for the organizations? We also classify innovation into two models. Is this an incremental innovation or is it something clean sheet, which is brand new? So for example, we were trying to go after direct acquired contracts, and then we said, okay, how do we support the payer model? So that was in a payer model, especially for Medicare Advantage, how do we provide a new set of innovation and innovative capabilities for that particular market? So that's, we internally call those kind of things as clean sheet because those are big programs, takes a lot of time, a lot of resources, and a lot of time too. So if there's incremental innovation, which is, okay, let's figure out how can we provide basic reports that is immediately available in the in a clinical workflow. So those are what we call incremental innovations. And we look at has the success been adopted in terms of innovation, has the success being adopted into the clinical workflow? Have we learned from it? What did we learn? Because there are always a billion ideas coming out from our CEO who reads a lot of airline magazines, from our partners, from our clients. So what are the things that we could implement, and what did we learn in terms of stretching our people, in terms of changing our processes, in terms of quickly adopting some changes? Those are the things we look at.
Thanks very much. So we've talked about success, we've talked about what innovation is. Without sharing a vendor, can you talk about, or you may have in the past, let's talk about maybe what is more of an epic fail, not epic as a product, but fail. But I mean, a failure, an innovation failure that you've either been a part of or come across in your organization. Because I think the issue of healthcare and business a lot of times is we are drawn to the stories of magazines which have a marketing spin, which are always nice and rosy. And a lot of times the best lessons we get is kind of behind the curtain where it's kind of ugly, messy, and you have to fix it. And so I'd love to hear about the innovation fails. If you pivot it up to this bright rainbow, but we don't really need to know the rainbow right now. Just what were the failures that maybe had to be killed, and what did you learn as an organization or as an individual in that process?
So, I can talk about the process of the technology. It's basically trying to, I think it was said earlier, looking at a very shiny technology and trying to figure out, I really like that. And trying to quickly build a business case because somebody liked it. And especially somebody at the senior level liked it. So coming up with all the best business case you can think of, building the ROI. And then forgetting to ask the basic questions with the providers. How will this be used? How can this help you have better conversations with your patients? How can we improve the patient-provider relationship? Not having all of those conversations and then trying to impart those. And change is hard for anybody, and change is especially hard for providers as they start dealing with those new technology that doesn't really work well. So time and again, where that's what I've seen, it's like it's nice and shiny when you look at it at 10,000-foot level, but then when you don't ask the right questions with the people who are going to use those, it becomes a big failure.
Yeah, I'll kind of talk in more general sense, no specifics. But I think when we look at the shiny objects, it's a lot of mobile technologies, applications, things that people find that they think are going to solve a problem. And really the issue or the failure that we run into is it's one thing to implement something in a small pilot pilot, and it's a totally different thing to design something that's scalable and supportable long term. And sometimes there's some really tough conversations that need to be had when we have what we would call a successful pilot, and then turning that into something enterprise ready and supportable. So when I look at failures, that's kind of a change management and problem definition failure, which I think sets you up for success or failure on anything you're going to do.
So I'll point out two key things. One, sustainability, the other, change management. And I'll take you back to a few years ago, where you may have heard of a product called EMC Documented. It was going to save us in healthcare because it was going to do enterprise content management, unlike what you've seen before. And many organizations, including in the previous life, one of my organizations, bought the tool, living the dream, off the PowerPoint presentation. And then when they tried to implement it, what they found was trying to look at the workflows across an organization that might have 10,000 people, and then getting them to change their workflows was a completely different project, and it had nothing to do with turning on a piece of software. And the same analogy can be applied to electronic health records. So we're currently doing a Cerner to Epic migration. It took us probably about 15 years to put Cerner in, and we're trying to do Epic in 18 months. And what we're also seeing there is it takes a lot of effort to get everybody on board, engaged, and willing to do the same thing in the same true growth direction. So I don't always think it's about what technology you buy. You can buy some of the best technologies and they will fail. But every time I see people doing innovation, the best thing to do in innovation in my seat is to put it in, but don't be there when it goes live, right? Because you're going to have to own it, and then you're going to have to sustain it. And that's where it gets hairy.
Sitting on either side of me is a problem, I think. I don't know what more to add to these conversations. I think our epic failures, if we could call them that, are typically stem from not having a real true business case defined before we launch a technical implementation. I think that's been echoed here as well. We tend to fall down when we chase the shiny object, or we try and copy what others are doing or what we think others are doing. We try and reverse engineer and we come up with our own way, and we work at that for a while before we realize we haven't even come up with what our business need for this piece of technology is, and who are the right stakeholders from Virginia Mason to include, and how should we roll this out in a way that's usable. I think that really is a root for us.
Thanks. So another conversation I've heard, and I think Zach read this before, is the idea that how finance, or the money side of healthcare, are you innovating to do something new and exciting, or are you innovating to actually save money? The novel idea that healthcare cost centers somehow plateau or possibly shrink, and what do you see as far as innovation being able to cut costs or set operating costs in order within IT itself or outside of IT?
So I'll use our example. We're a health IT shop with about 500 people. We're spending about 9% of our revenue on IT. The industry standard is about 5%. The challenge for a healthcare IT technologist is, do I spend 15% and do I turn away patients and not take care of them? Because a child, it takes about $250,000 to treat a child with cancer. So every decision I make in tech could impact a child. We do $200 million in uncompensated care every year. So that's the balance we use at Children's to figure out what we buy in tech. But I would absolutely say that the tools that are coming out around automation, reduction in FTE, those are the things we certainly at Children's and others are looking at, because you can't sustain, I can't have 5 more project managers and 6 more FTEs to support projects. What I need to do is work with the vendors in partnership and find those automated tools to make my operations as lean as possible, so that the money I release can be invested in clinical care. That's certainly the focus. And certainly when I talk to colleagues, they're all trying to do that. So there is some efficiency models in place.
I'm on the same page. You know, when I'm looking at even something down to FTEs, opening up a new FTE to hire a new server analyst or a network engineer, in the back of my mind I'm thinking, how many nurses can we hire in that place? Maybe it's a one-to-one. But even further than that, you know, I have this feeling that we can't save our way to success, so we need to look at growth. And we need to really go back to truly finding the true cost of ownership on these technology investments. So we're kind of moving from a CapEx heavy budgeting perspective for technology to operating expenses with cloud and SaaS and all these. And so we're having to have some really tough discussions where previously with our executive team, we would look at a new project, new technology we want to implement, and there was a huge capital investment up front. Now it's switched to ongoing expense, and it's a big operating impact. So we're having those conversations and kind of trying to build some competency and understanding across our executive team to kind of really understand the change and the shift from on-prem to off-prem.
Yeah, so we are looking at what kind of processes can we truly automate. So for example, when you look at coding, how much scale can we get in terms of improving the coding and using NLP technologies to help improve that? Because for us, that scale is important, but it's also important to make sure that it is done the right way, and can we use some level of technology to speed up the process, but also use some level of governance and people to validate those. So that's how we look at some level of technology investments.
Even
I would just say that, you know, within IT, we're innovating in our own processes to reduce total cost of ownership, and I think we're all trying to do that. There's a lot of pressure to spend less on IT so we can spend more on patient care. We innovate outside of IT at VM to improve quality and safety, which we believe to reduce cost. You know, ultimately the two are tied together, and we have to find that sweet spot of how to find the balance of technology and human effort to produce the highest quality outcomes at the lowest cost.
Okay, thank you very much. So before we go to the audience for questions, a little two here, less difficult questions or a little different. So what is the most interesting technology that you use personally right now, just in your life that you've adopted, say, in the last year or two? And then if you could create anything in healthcare right now as far as a technology or invest in, what would be that shiny thing that you think would actually change the world in healthcare? So something, so just a way, something fun, and it may be not something that has to be out here right now, but maybe something that you think would be, I think it was John who said this, the ways. What is the ways for healthcare? So the ways after. What is that now for healthcare? So may start with the easier one. What's the technology that you use in your personal life?
That's a big question. So a little bit of personal background. I've been training for a vet. I'm recreationally a weekend warrior type person. And I have all my training plans and everything on my phone. And you know how this relates to healthcare. I think my phone has more information on it than probably my electronic health record. You know, I got my heart rate for the last 6 months probably on here. You know, my weight, how many hours I've slept every night. It's all here. It's all controlled by me, and I decide who I share that with. I can connect, you know, all of my data sources on my phone. Like my coach has this information, Garmin has this information. You know, I can see it in multiple ways. And so, to go back to what I think we do in healthcare is a way for patients to do the same. You know, patients should be the center of the healthcare system, and I should be able to say, you know, I want my data from all of my providers on my phone, and I'll share it with who I want to share it with. Right now, we look at that in the reverse in a lot of ways. As Virginia Mason, I'm kind of a steward of the patient's record, and what am I going to expose to that patient, and what will I expose to other providers? To me, that's a little backwards, and I think to really improve the system, we need to turn it inside out.
I think they're really hard questions because personally, as a technologist and a physician, I'm trying to unplug my life, right? Because the more technology we use, the more we are glued to that digital Actually, in our organization yesterday, we actually have a research group that studies digital addiction in children. And there was a presentation as part of National Health IT Week. It was really interesting to watch what that particular researcher was talking about in terms of how many people are glued to their devices. So my personal view is I'm trying to unplug, I'm not having a lot of success doing that. So I would say I have hundreds of apps on my phone. I don't use them all. Probably the most useful app personally that I've downloaded recently is MyFitnessPal. My doctor says I have high blood pressure, so I have to reduce my weight. So I've been using that recently. In terms of technology, the next shiny thing, I think my view is, certainly at Children's, we have more technology than we can consume. So what I'm trying to get my organization to do is sweat the assets that we have. Right now we have 749 applications running in the organization. So if we can really help our clinical users, our patients, our families, our caregivers use the tools that we have heavily invested in without buying any more shiny tools, that's the focus for my team.
So I'm similar to you, Ron. I'm a runner, and so I use a lot of different running fitness apps. But I would say the technology I come into contact with most often is kind of a love-hate relationship, and I'll give you a little backstory. So I've always prided myself in having a really good sense of direction, and my wife would say she doesn't. And so my superpower has been being able to find where we're going, not the most direct way, but we get there. And so using Google Maps and Waze and all these things has kind of taken away my superpower and made my wife much better at this stuff than me because she trusts it and I don't. And so, so that's kind of that love-hate relationship with technology and what I probably touch the most. As for what's on in the future, technology innovation, I couldn't agree more. I think we need to get more out of what we have already, use what we have, be really proficient, mastery of the tools we have. But I do look out there and I think, when I think back to 2002, there was a movie that came out, Minority Report. There was a lot of really cool whiz-bang pow CSI type stuff where they were using augmented and virtual reality to solve all kinds of problems. And I thought, well, that's really cool. That'll probably come to fruition in the next 10 years. Well, it's almost 20 years later, and while there's a lot of pilots of the use of VR in surgical and acute areas, I think that the best use case I can think of and the coolest thing I can think of for the use of that type of technology would be something a little more simple. So something out in the ambulatory area, something for expecting parents to interact in a 3D imaging situation using virtual reality to look at their unborn child, something like that. I think those are the kind of cool whiz-bang pow things that are in the future that could actually be done in the next 3 to 5 years.
So I'm just going to some of the comments that a few made. I'm a runner myself too, so I use my Apple Watch and my MyFitnessPal app, so it's fully integrated. But I also check out the other apps that are related to running, so I know exactly where I run, how much did I run. So that's very useful for me. So that's what I use for. In terms of future technologies, I would say, we want to enable members of our members to have access to all the information. Patients should own their information, whether they go to a primary care, they go to a specialty care. So it would be really cool if there is one app or one device that recognizes, oh, there's a senior who's come here. It is all of this, claim history or hospitalization history, everything that they can easily share with anywhere. So I don't have to sign 10 consent forms. I don't have to sign 10 other forms that I have already signed n number of times and I have filled in n number of times. So it automatically recognizes that information is available either on my phone or my app, and it carries over everywhere so that any specialty provider I go, did you do this screening? I don't know. When was the last tetanus shot done? Oh, it was 5 years ago, or maybe 6 years ago, whatever it is. So all that information is available at the hands of the members including their cost, how much did they spend when they were 20, how much did they spend when they were 30. All of this information is available in claim systems or EMR systems or other areas. It'll be just be fantastic if we have, and it's getting there with blockchain technologies or cognitive computing, but available at the point of care. So the member can have easy conversation with the provider, because half the time they don't remember what happened. I don't remember what happened when I got my shoulder dislocated when I skated. So what medication did I take? I don't know. How did I go through surgery? If what medication did I have? Do I have allergies? Well, I used to have, not anymore. So things like that would make that patient-provider conversation easier, both on the patient side and on the provider side, which improves the overall health outcomes. And if we have that all in an app available, whether it's an app or it's just part of your device, maybe inside your body, I don't know, would be really good to have those, so we don't have to keep having tons and tons of data everywhere.
Thanks. I could keep asking questions. I have the conversation, but I know you have questions out there. Who has a question? Rodney, anything else? Start with you.
I'll speak about it. I've heard a couple of you talk about moving towards the patient being the steward of their data. I, as a physician, if I lose a note, I'm accountable. I get a delinquency notice. If as a hospital we lose a note, we're accountable based on HIPAA. Do we think patients are ready to be held accountable for being stewards of their data? Google and Microsoft would argue that they weren't, and that's why HealthVault and those things failed. But it's a panacea that we talk about, that, the patient should be at the center of their data. Is every patient ready to be accountable for being the center of their data?
So the first question is, who owns the data? So depending on where you are in the world, that varies. So in the UK, for example, the government has made the statement that the government owns the data, therefore will control the data. In Switzerland, it's the polar opposite. The patient owns the data and doesn't reveal the data to the physician without an access card. So yes, patients can be stewards of their own data. The challenge is the data truly interoperable across health systems? So yes, I agree with, yes, the patient should have all the data at the palm of their hands, but we're not doing a very good job of translating that data across health systems. So yes, interoperability standards are there. We're still victims of being held to ransom by X number of EHR vendors. So I think it's a combination. I think first we have to get the data moving from one organization to another freely. And then, yes, we could restrict that data. The patient could have access to that data, but at the same time restrict access or approve access to that data. So I think some standards need to be set, right? Who really owns that data? Some health systems may think, we at Children's may think we own that data, but is it patient data? Is it our data? And we're still not sharing it very well.
You want to?
Yeah, I would say, from our perspective at least, patients own the data because you want behavioral change in their patients. And in order for you to have a behavioral change, you have to have enough transparency around that data, what is that, and how to make it meaningful for the patient. And so that's the first step. How do I own the data? There is certainly issues around interoperability, but the security of the data is, it's capabilities around the security of the data is slowly improving, and there's a lot of opportunities, especially with cloud solutions, to figure out how to protect it and save the data. But ultimately, I believe over a period of time, with a lot of education, with the security in place, and then owning the data will help drive the behavioral change. Because at the end of the day, if I know my employer gives me great insurance, I'm not going to go really make preventative care a true option for me. So if I have the data, I would at least be a steward of that, and then start figuring out how to make behavioral change and drive health outcomes. And so from that perspective, it's really important for the patient to have the data.
I was just going to add on that really we're a lot more naked than we think we are. Most of us, this was a big thing a few years ago, everybody in America has voted that, for a $1 app, to get a Mac for $1 or for free versus spending $50, we'll give up a whole bunch of personal information. And just what's floating on there on the internet for demographics, you can pretty much figure out most anything about a person, with 99% accuracy, what their health is and what their risk is, just, on those advantages. But more questions from the audience?
I'm just going to add one thing for it. I would say one big kind of differentiator, or I guess barrier to assigning who owns the data is assigning risk with the ownership. And I think that's kind of part of your point. So with the ownership should go the risk. And I agree. I think we should own the data. That's a personal opinion. But the risk, you can't incur the risk as an organization and then release ownership. It's a very, very tough.
Hi. Coming from, was born in Canada, for me having access to healthcare is still foreign to me that not everyone in the United States have access to healthcare. So I'd like to find out how you see your role playing to actually bring increased access while keeping the challenge to stay and remain competitive. How IT will influence that market. Exactly.
Good
Or
question.
high return on investment here.
It feels like we loaded the audience with people asking these kind of questions. No, I mean, IT has a part to play, right? So we have to have the tools and the security and the systems in place to make things bookable, available, capacity and demand. But as an organization, the challenge is how do you manage capacity and demand? So at children's, some specialties is very hard to get an appointment. Access isn't easy. So we can facilitate that with putting in tools to help. But what we can't solve is the lack of training, or, we're not training enough doctors, we're not training enough nurses, we're not training enough specialties. So money has to be put in to improve that access. That's certainly what we're seeing at children's. So it's a combination between IT supporting the business, IT being involved in the operational side of that business, there at the table, and then working with the clinical staff to figure out, how are we going to make it, how do we turn healthcare into that consumer type market that people want? Can I get an appointment at any time, any day, any place, anywhere? It's going to take some time to get there.
Yeah, access is an interesting question. We asked our members, one of our satisfaction questions, did you get an appointment in the time frame you wanted? For some, it's, I got up, I feel sick, I want an appointment right now. For some, it's like, okay, I just need to get it in 2 days. For some, it could be a week. So, how do you use technology, whether it is technology to create a easy scheduling capability, or whether it is using virtual technologies to create a virtual care solution, so that for sick care, you can provide those. So those are kind of things that you can think about how technology can really help, but I think in the end it comes down to, do you have the right number of providers for the population that you're going to support in terms of panel sizes, and if not, how does informatics or technology can help make those decisions. But given there's so much lack of, we talked about primary care, there's so much lack of primary care providers, it's a tough problem to solve, but technology can solve it more from a patient's perspective. How do I find the right appointment in the time frame that I want it?
So I think that most of the panelists today have talked about, innovating for a specific purpose or a business goal, achieving a solution to a specific problem. I'm kind of curious, are there any best practices that are universally applicable that you can kind of, general guide rails to make sure that your organization is innovating intelligently?
Well, with any innovation, you have to be ready for some level of failures, right? So if it is not you're not taking a big risk enough. No, I wouldn't do that where I'm putting systems in the ER. So you're going to look at how big of a risk is that? How are you stretching your teams, and how are you looking at what is the member experience going to be? So at least from our perspective, we're all driven by how does it drive member experience? It makes it easy for our members to have easy access to our providers, and then looking at also how to drive health outcomes. Because our belief is if you improve the health outcomes, the costs will automatically come down. So any innovations that helps move the health outcomes will be really useful. And so I don't know whether I have a standard metric of looking at use all of this process, because it depends on what your culture is. It depends on how much of a change management is associated with that particular innovation that you are trying to adopt into your organization. So it's varies by organization.
Yeah, I think, I'll frame it through the lens of change management. So awareness, are we aware that we need to be an innovative organization? And then what does that mean? And then getting everybody on board with the desire piece, so following ADKAR. But when you look at just kind of practical day-to-day, how you choose one innovative project over another, I think you need to make sure you obviously aligns with mission, but be aware of the capacity of people, the people in the organization need to execute on the great ideas that we come up with, their capacity to kind of hit that change saturation point. So choose wisely. Choose something you can execute well. It's better to do one thing well than 10,000 things.
Thanks. Another question?
What do you find to be the biggest barrier to innovation in healthcare? And I think the second part of it would be to sustain that innovation and continue to improve. Because I feel like in healthcare, we're always kind of following the trend of the other industries. The voice recognition is another example. It came with a kind of consumer, now it's coming into the healthcare market, but why are we always kind of behind?
Sorry for a little interlude there, technology called. The panel. But I think we have a little bit of a paradox in healthcare because there are so many opportunities. It's hard to pick where to apply innovation and really focus efforts. And so we can get a lot of things going and not really land. And I think that's one of the barriers is really just actually figuring out what we want to do and applying our very limited resources to that goal.
It is also a risk-averse industry. I've been in the industry for like 8 years now, but coming from its other industries have adopted easily because you don't have a huge compliance team telling you, you can't do this because of these regulations, etc., which may or may not be true, but because it's traditionally done this way, that's number one that I've seen. I think the point was made earlier, providers in some aspects, it's their adoption, like how does it help improve patient safety or how does it help patient care? If it's not clearly articulated, they don't buy in. And also, get them involved sooner. Even when you're in the ideation phase, like we're thinking of this particular idea that could solve it, or we are thinking of this technology to get them engaged even way up, even before you have formally kicked off the project, might reduce the number of barriers that you have. And then there's always going to be some level of naysayers, and so I think about finding some champions. And if those champions, especially in the provider group, they can actually really help you kind of reduce the barriers for others to follow.
Curious, talk a lot about data and the retention of data, who owns that responsibility, and then innovation as well, and patient safety. Just curious what each of you are doing as it relates to connected medical devices in your organizations as it relates to data and patient safety.
connected medical devices in the biomedical space or wearables and things in that space?
No, more so biomedical, inside the provider space.
Yeah, so that's probably one of the things that keeps me up most at night.
That was actually going to be the second half.
Yeah.
To Dwayne's question, what keeps you up at night of the entire time?
From a security perspective, it's obviously the human element that we're all going to say that. The biomed, kind of getting my hands wrapped around the biomed space and all those devices is very challenging and the most stressful part of my CISO hat. Most of the manufacturers in the biomed space are really behind. They're very far behind from an operating system perspective and security posturing and hardening of the devices. So, and then there's not a lot of really great tools to go out there and crawl the network and give you visibility. The first step in securing anything is knowing what you have, so getting the inventory of what you have. So there's a lot of challenges in that space. I wish I had the answer.
I would agree. I think all CIOs and CISOs face this challenge around everything else that's plugged into the network, and that could be medical devices, but also what we plug in, physicians plug in, nurses plug in. Many are trying to integrate the data from those devices into the electronic medical record. A lot of healthcare organizations have done that. We've embarked on that journey, I'm sure others have as well. But the biggest challenge will be the security aspects of that and the fact that the vendors should actually be given a federal mandate to comply with security as of 2019. But of course they have great lobbyists, so therefore they won't have to do that, will they? That's really the challenge. Let's get off Windows 3.11 on those devices and move to something else.
We'll take a question from over this side here.
So I want to zero in on a comment that Dr. Shadri made. You had said that you're not entirely convinced that we're going to be able to save money from innovation or technology. And I don't mean to call you out because I tend to agree with you to a degree, but I'm curious if you could talk about some of the challenges and how you've overcome those challenges in measuring the actual benefit of some of the new innovation, because I mean obviously if the only criteria we have to evaluate a fish is how well it climbs a tree, then it's going to seem like a really horrible idea or investment.
Yeah, so my comment was directed to, so if I'm going to spend 10 million on a product set, and I call it innovation, whatever that product set is, am I really going to get my 10 million back? And don't get me wrong, I'm not looking always at cash benefits. There are absolutely soft benefits clinically for certain systems. But what I'm not seeing, certainly in my own organization and other organizations I've worked in, is a very clear benefits realization program. And a lot of times when you write business cases, and I'll use the example of the electronic health medical record, right? Everybody writes a business case to say, I'm going to spend 200 million or something on Epic or Cerner, and I'm going to get 300 million in benefits. And then that's how a business case gets approved. And I challenge that, right? Because I challenge organizations to say, show me the money or show me the numbers. So I think what we've got to be better at as technologists is writing realistic business cases. So we're putting in Epic now. Our business case is actually built on zero benefits, right? I told the board, this is the cost of doing business in 2019. We have to have an electronic medical record that works for the clinicians. But I think we've got to work collaboratively across healthcare organizations to build a templated, standardized model of what benefits are we trying to measure, and then do a good job of revealing that. So fine, you could spend 10 million on innovation, and maybe it brings you 2 million in cash benefits, 2 million in cost avoidance, and 2 million in soft benefits. But when I look in the market or I read the literature, I don't see that from other organizations. And before I was working with the CIO, I used to work for Gartner, and people used to pay me lots of money to figure this out. And I traveled the world trying to figure out where all these cash savings were and where they were hidden. So all I'm really getting at is, let's build a better, more sustainable model of benefits realization and then let's reveal that, and let's all work together in collaboration to improve on that. So if my colleague here has something for a program he's done, I'd love to get involved. Can I borrow it? Can I use it? Can it help me then deliver this better?
I think you made a great point in collaboration. You know, we're all working on the same problems, and we're all developing our own solutions to the same exact problems, and our solutions are probably very, very similar. You know, 80-20 rule, 80% of it's going to be the same, but we're all spending our own resources to develop it. So I think the more we can collaborate and share across health systems and with our vendors, the better off we'll be as an industry.
I would just add that kind of keeping it focused that we have a quadruple aim, not a single aim. It's not just finance, it's patient experience, provider experience, and quality. So the ROI calculations, methodology should take all four of those into account. And I think that traditionally we've been, as a CIO, I've tried to build my case from a financial perspective, and that's one perspective of four.
So a question we haven't really talked about with innovation is, what do you think the risk is of the Amazon or someone outside of the industry revolutionizing this industry? You know, will the healthcare we know not be around? Will it go to somebody like an Amazon that maybe has that provider piece, that deliverable piece, delivering to the end consumer with a different bent than what is the norm in the healthcare industry? Is that a concern or thoughts that you think about it?
I don't think it's a concern. I guess it's a concern. Short term, I don't think it's a big concern. Long term, you know, I think you either are part of a change and you embrace it, or you're bowled over by it. So I do think that they definitely can eat our lunch every day on their being in tune with what consumers want and need. So we can learn a lot from there. They vastly underestimate the complexity of healthcare, though, I can tell you that. And it doesn't have to be as complex as it is, but it is. And the most simple problems from a technology perspective are very complex when you take workflow into account.
Alan, you made a funny face. What are your thoughts?
You didn't prep us for that question, so I was curious. I mean, I think there is something about it. You know, I think as consumers are more willing to spend their own dollar on healthcare, then that frees up space for more innovative ideas, and for companies like Amazon and some of the others to offer different business models and different and easier, more convenient ways to access care that people are going to be willing to spend money out of pocket for. So it's not going to necessarily be subject to the same requirements and regulations that you would be, you know, if you were receiving care from Medicare or from your health insurance provider. So I think we shouldn't underestimate that. You know, people's willingness to spend their own money for something that they see offers more value than what they can get from existing healthcare institutions.
So I think if Amazon, Walmart, and others want to disrupt healthcare, bring it on. They should, right? If they want to come into this marketplace, understand it, and make a difference. I think we as healthcare technologists do have a leg up on them because we understand some of those complexities. So maybe we can work in partnership. They'll bring more access potentially and more digitization and automation. Maybe we as healthcare technologists need to have more courage to embrace our own technologies, because some of the barriers I see to innovation, even in my own group, is us as technologists saying no. So you actually have key clinicians saying, we'd like to help get to certain points, and us saying, we're too busy, we're overworked, etc., etc. So if Amazon comes in, that's going to create a healthy competition. And if we are not a good service provider to our healthcare organizations as a health IT shop, then maybe they'll buy services from Amazon, and then maybe we'll do better. So I don't think that that's a negative thing. I think, but they've got to show us a roadmap as well. I was talking to Amazon yesterday. I don't know what their roadmap is.
Yeah, so I used to work at Microsoft, so we all basically used to call this best number 2, when compared to Apple. So when you think about Apple or Walmart or Amazon coming in, certainly they are going to change the expectations of the patients a lot more, a lot faster. And as organizations, traditional healthcare organizations can learn from some of those. And by virtue of them doing those, because traditional healthcare organizations have so much data, so much process, so much experience of what has not worked well, it might be easier for some of those organizations to adopt and change rather than trying to reinvent the whole wheel, or trying to take on some experimentation that when you are trying for new budgets or you're highly budget constrained, it's very hard to try it. So just say let's Amazon or Walmart try it, work with them, partner with them. And there's also so much shortage of primary care that they are trying to fill in, which really help specialty groups a lot more, because they can then focus on patients or members who absolutely need that level of care and let Amazon or Apple deal with the primary care.
Let's add one last smart question. As we sit here talking about innovation within the context of probably the most technologically advanced healthcare system in the world, how do we reconcile that with the fact that we're not in the top 20 in the world in outcomes, and yet we are the most technologically advanced healthcare system in the world?
We're also the most expensive healthcare system in the world.
That was just
But that still goes back to how are we really looking at our business, right? So we debate this internally as children's a lot, right? How much we are the most expensive pediatric health system in the world, by the way. So we're debating this a lot at our organization as to why we are where we are. But it's a combination of issues. One is, do we have the right workforce to treat our patients? Are we focusing more on primary care versus secondary care? Certainly, the European model works well because it's all primary care centric. They don't even let you get into secondary care unless you need it. Primary care isn't a strong suit in the US healthcare, right? If you just look around Seattle, can you get an appointment with a primary care doctor on the same day? In Seattle, absolutely not. In the UK, in 20 minutes, you can have an appointment with your primary care doctor, who will then take some action and hopefully keep you out of the emergency room. But at the same time, to bring those costs down and improve those outcomes, we probably need to think about how care is delivered. So we've talked about that virtual care, and then at the same time, why are health systems still building 1,000-bed hospitals, which cost money and therefore are expensive to run, where you could have 20 clinics doing similar function. So I don't think we've really thought that through. And other places that have been doing population health management, the Europeans or the Australians are way ahead, because that's what they figured out.
So what I'd like to do is let you stew on the last question you want to ask and take that over to the next room where we're going to have the appetizers, we've got drink tickets for everyone here, and we want to give you an opportunity to do more of that collaboration. So the project at HIMSS, which you guys can have today, is education, collaboration, and really just these type of opportunities to get together and connect. So the next 2 hours is just an opportunity to do that. So I hope you'll pick us up on that, have the opportunity to connect and ask these type of questions, because really the answers are going to come from what we all put together in these different topics. So I want to thank the panel here. I want to thank the other members of the CXO advisory group that helped put these type of thoughts together. Scott was talking about change management. On October 9th, we have a breakfast, which is at 818 Stewart. It's going to be on change management. It's on the HIMSS website. Scott will be presenting with John Dwight, who's the CIO of Evergreen. They've got 2 consultants and people they've worked with in that whole space. And that is kind of what we talked about on the CXO level, is that really innovation behind the curtain has everything to do with change management. So if you want to learn more, that is going to be the place to hear more, but also a chance to collaborate, ask more questions, and continue your own personal journey. So thank you very much, and have a great day.